Morning, dear students. Today is a day we have gathered here on this virtual platform to have a visit related to psychiatric nursing chapter. And I'm very happy to introduce a most eminent person in the field of psychiatry. Sir, we are privileged to have you here as a resource person for our virtual platform observation visit for dear third year BSc nursing students. He is none other than Dr. Ajay Muthukumar. Uh, he is a consultant psychiatrist from Athma Hospitals, Trichy. He did his undergraduation MBBS, that is at Kanyakumari Government Medical College. He completed his post-graduation MD in psychiatry from KAPV Government Medical College, Trichy. He is specialized in electroconvulsive therapies and RTMS from NIMHANS, Bangalore. He has been involved in de-addiction treatment with excellent success rate. He has published journals in Tamil Nadu Dr. MGR Medical University Journal Portal. He regularly gives health talks about various psychiatric disorders in television, radio shows, and an eminent speaker in various psychiatric conferences and at the public forum. His most interest area is de-addiction and forensic psychiatry. With this intro, I hand over the session to Dr. Ajay, and I hope our students will have interaction with you also and get benefited. And it will be an interesting session to tour on this virtual platform, your esteemed organization, sir.
Thank you, madam. Okay, good morning, everyone. Am I audible? Am I audible?
Yes, sir. Student muted, sir.
Okay. Thank you, sir. Okay. Welcome to Athma De-Addiction Center. So, in the middle of the COVID-19, you cannot come directly and visit our de-addiction center. So, in thought of that, your organization, your hospital has arranged a virtual visit. So, I am Dr. Ajay Muthukumar, consultant psychiatrist and de-addiction specialist working for Athma Hospitals and Research. And so, we have, this is our services, entire services. We have started Athma Hospitals since 1993. And we started our de-addiction center in 2002. And still now we have treated almost 30,000 substance abuse patients and they are treated very successfully. And I have experience of treating de-addiction patients for the past 2 years. And so this is our entire services in a nutshell. We have a mind care hospital, that is Athma Hospital and a de-addiction center. And we have a rehabilitation center named Shantivanam, which are harboring 120 inmates, more than 120 inmates. And out of that, 1/3 of the patients are de-addiction patients, that is all substance addicted patients who have not shown very much improvement in de-addiction center. So that we transferred them to a rehabilitation center. We have telepsychiatry. We can see the patients all over India, all over the world. Even we are seeing patients from Malaysia and US. And we have pickup services. And we can pick up any patients, psychiatric patients who are resistant to come to hospital all over Tamil Nadu. And we have emergency psychiatry, and we have special school for intellectual disability patients, intellectual disability children, and mentally retarded kids. So this is our entire range of services. And coming on to the outline of today's talk, we have seen about the organizational setup of the Athma De-Addiction Center, and what are the various background and various services we provide at our de-addiction center, and various treatment measures done for the patients in our de-addiction center, different rehabilitation measures and measure activities provided by our center, and a nursing responsibility in the de-addiction center. Why I'm saying this is, there are many de-addiction centers in Tamil Nadu as well as in India. They are harboring more than 100 de-addiction patients. They have adequate number of patients, but there is no consultant psychiatrist to treat the patients properly. See, we have a de-addiction center, we go for rounds daily. But this is not a scenario in all the situations. In many de-addiction centers, they are running without even license, and they are running the de-addiction center with the help of staff nurse. So that's why it is very, very important for you. Psychiatry in your BSc nursing curriculum is very important because of this. because you have to, since your study is almost 6 months, I think, so that we have many students coming to our hospital to nursing students coming to our hospital for visit. When I asked them, they studied for psychiatry for around 6 months in second year or something. So why is that important is you have to manage the whole de-addiction center with this 100 patients. You and the psychiatric social worker will be not only in, I'm telling, more than 80% of the de-addiction center run through only staff nurse. Doctor will give phone orders and you have to maintain it and you have to take care of the entire, you have to take care of the entire de-addiction center. And finally, we have Athma de-addiction center in community level. In what level we reached that, and we of what level we have created the awareness and going to tell by mainly by pictures and videos only. So this is what important and today's outline on the top. And this is our hospital, Athma Hospitals and Research. It is a 50-bedded hospital. We have two ICU for 2-bedded ICU for psychiatric violent patients as well as psychiatric overdosage patients, any critical patients. We admit in the ICU, and it's a 50-bedded hospital including general wards and rooms, and we have providing ECGs and almost all services what we are providing in the NIMHANS Bangalore we are providing. So this is our de-addiction center. It is almost a 4-floor building, 40-bedded hospital, and it consists of 2 acute wards, 2 cells to restrain the confused or restless patients. And it is attached to Athma Hospitals and Research. Any sort of emergency or any sort of confusion, that the patient will be transferred to Athma Hospitals and Research. We have 4 counselors in rotation, and they will be in the de-addiction center 24/7. There are 2 staff nurses trained in psychiatric care, especially trained in psychiatric care, and they are trained in rehabilitation de-addiction center for the past 2 years. They are working mainly in the de-addiction center only. And we have 1 yoga therapist, and we have 5 consultant psychiatrists on rotation duty to the de-addiction center, visit to the de-addiction center. And we have attached kitchen and dining. The patient cannot come out. We have a secure 2-level protection to prevent the escape of the de-addiction patient. That is what very, very important in the de-addiction center. The patient cannot escape. Once the patient comes into the hospital, he cannot go out even if he's going for any important functions like marriage, even if he's own marriage, that we cannot allow the patients after admitting the de-addiction center. If you want to go out before the admitting in the de-addiction center, you can go. So there will be secure 2-level protection to prevent the escape of the patients, because the confused patients and restless patients will be there. They are more prone to escape from the due to the alcohol craving. They can there is a risk of escape. So prevent that, we have a secure 2-level protection with security guard 24 hours in all the 2 levels. So general rules for admission in the de-addiction center. This is not for our hospital only. This is almost for every hospital, every de-addiction center. So the admission in Athma hospitals is for if a patient comes with an alcohol, any substance, the patient is willing for de-addiction. This is the general scenario. The patient will be admitted in Athma hospital for 5 days. And if there is no complication, the patient can be transferred on the 6th day to the de-addiction center. On 5 days, mainly if the substance is an alcohol or cannabis, we can see for any withdrawal symptoms, mainly seizures, confusion, and any physical ailments we can treat here, and we can transfer the patient to de-addiction center. In the normal period, the patient stay to gain motivation to stop the substance is 25 days. So we can transfer the patient to de-addiction center. The patient will stay there alone without family. The patient will be there for 25 days. So if there is no motivation after 30 days, we can do a test. We cannot rightly send the patients after 25 days. That is, we will be fully de-addicted. He cannot drink in future. We cannot send rightly like that. So we do a test called Q exposure therapy. I will tell later. So Q exposure therapy we will done, and if there is no motivation seen after 30 days, we have the 30 more days. We can make the patient stay in the de-addiction center for 30 more days. If there is no motivation on again test CET test after 60 days, the rehabilitation center there will be they will shift it to the rehabilitation center, as I told Shantivanam, that is for 3 more months. So in general, we don't know about tablet disulfiram. That is the tablet for alcohol de-addiction, especially. So the tablet we start on 21st day after the first CET. If the first CET is negative, that is the patient is showing some motivation, then we can start tablet disulfiram. And after the patient discharged from the de-addiction center, if he gains good motivation, then he has to be follow up every month. on AA meeting, that is Alcohol Anonymous meeting, that can be done in every fourth Sunday of a month. So Alcohol Anonymous meeting. Okay. So when you are posted in a de-addiction center after your BSc nursing or MSc nursing course, if you are training in psychiatric nursing and you are posted in a de-addiction center, you have to learn some terms. Then only you can know about what. If you know about addiction, then only you know about de-addiction. So if a doctor gives some order through phone, if you know about that term, the doctor is saying the patient is having increased craving, the patient is having increased tolerance, then you have to know about those terms. So if you know those terms, then you can identify the risk the patient is going to see in the next 2 to 3 days, next few days. So substance is a term, is any drug or a medication or a toxin, whatever it may be, not only drug, medication or toxin, any form that shares a potential for abuse and dependence, then it is called as a substance. So even if it is a gaming addiction, that is also a substance. Substance now, the gaming, that is a PUBG, Free Fire, these sorts of games, TikToks. So these also comes under addiction only. So now they have included that also in addiction, not only alcohol, cannabis, or heroin. So these are the important terms. First, we're going to see about tolerance. What is tolerance? Tolerance, as you know, as a general term, the dose, that is the previously given dose, that is if the patient is taking 180 ml of alcohol previously for the past 5 years and he is not getting the desired effect, that is the bode, that the desired effect, if he is not getting the with the 180 ml after 180 ml intake, then it is called as tolerance. The patient needs much more dose, a larger dose than will be required to produce the same effect. That's called tolerance. If there is tolerance, that indicates the patient is going for chronic dependence. So dependence, what is called dependence? We know about addiction. What is called dependence? Nothing but both are same. It's a synonym for addiction. So addiction, if the patient is saying, randomly saying if the patient is addict, then it is called as dependent. The patient is dependent. What is dependent? Both psychologically and physiologically, it is dependent. That is means dependent on that substance. If you withdraw or remove that substance, you will produce the symptoms on the body. You will continued use of this organism, he becomes necessary for the well-being of an organism. So if he devoid of the drug, he cannot run the normal life. So that is called dependence. Withdrawal means if the patient suddenly removes the substance, if it is alcohol or cannabis, suddenly removes the substance, then it will produce some psychological symptoms like tremors, physiological symptoms like tremors, psychological symptoms like agitation and irritability, anger outburst. Then it is called as withdrawal. So psychological or physiological symptoms that occur after a cessation of the drug or substance is called as withdrawal. Compulsive substance taking behavior is nothing but the patient will be taking the large, it is called binge eating. That is taking large amount of drug over a long period than intended. That is, he cannot control or cut down the substance use. He will be continuously taking the substance without knowing about the ill effects. His social, occupational, recreational activity are also be reduced. So craving is nothing but a strong subjective drive. The patient drive to use the substance. If the patient drinks alcohol till yesterday, and you admit the patient in the hospital on next day, the patient shows signs of craving. The patient will be restless, irritable, and the patient will be very agitated to take the substance. That is called as craving. So substance abuse is nothing but is taking the repetitive use of substance resulting in recurrent or significant adverse consequences. So simply saying, the patient is taking almost not dependent, not at the level of dependent. The patient is taking almost 2 to 4 2 days in a week, and mostly on the weekends. If the patient is taking substance, then it is called a substance abuse. So these are called gateway substances. There are only 2 gateway substances. That is called tobacco and cannabis. Why is called gateway substances? Because gateway substances, if the patient takes these 2 substances, then we can tell that the patient will take many more substances in future. So this is the best predictor of other drug use during adolescence. So this is the gateway substances. So if the patient is using tobacco or cannabis, then we can predict the patient will go for polysubstance syndrome. So coming on to addiction, as I told earlier, this is called a physiological or psychological dependence on any sort of drug that affects the central nervous system, in which if the removal of the drug will produces withdrawal symptoms. So this is ICD-10 classification. Wherever you go, in psychiatry as concerned. Without this ICD, now ICD-11 has come since May, but that's not up to not is very much used till now. But for the past 10 years, we are using ICD-10. So without this code, some doctors will write only code. So we can identify, we have to identify what are the substances. If the substances are coded under ICD-10 from F10 to 19, F is for psychiatry. Is alphabets A to Z are there. F is for psychiatry. F10 means the patient is taking mental and behavioral disturbances due to the use of alcohol. F11 means mental and behavioral disturbances due to the use of opioids. F12 means mental and behavioral disturbances due to the use of cannabis. F13 means the mental and behavioral disturbances due to the use of sedatives. And F14 is a patient is mental and behavioral disturbances due to the use of cocaine. And F16 is due to the use of hallucinogens, that is LSD. And F17 is tobacco. And F19 is all the substances, multiple substances. Okay. So commonly used psychotropic substances all over the world as far as India. Nowadays, India is also harboring almost all the substances as like Western countries. So now we are getting LSD, cocaine as easy as in Tamil Nadu also. So alcohol, opioids, cannabis, cocaine, amphetamine, sedatives, inhalants, nicotine. And do you know what? The most commonly abused substance in the whole world is not alcohol, caffeine. What do you take? Tea or coffee? That is the most commonly abused substance in the whole world. Because not everybody drinks alcohol, but everybody drinks caffeine. If you take caffeine, that is about the limit. If a single cup of caffeine, single cup of coffee takes around 180 grams of caffeine. If it takes around 3 to 4 coffees in a single day, then it becomes addict. That is the most commonly abused substance is caffeine. So what are the etiology? Why the patients are taking alcohol? So in this scenario, we can see 4 factors. One is biological factors. I'm not going to deep in this. We are going to see only the de-addiction. So you have to just know about what is the addiction and the de-addiction. Then only we can see about what is the de-addiction center, what we are doing in our de-addiction center. Just theory-based treatment only. So in real etiology, biological factors, no psychiatric disorders come de novo. All psychiatric disorders come from genetic. நம்ம பரம்பரையில இல்லாம எந்த மனநோயும் வராது. So comes as for psychiatric disorders concerned, substance use disorders also, குடிபோதை நோய் பரம்பரையில இருந்து தான் வரும். Family history of substance use disorder is a very strong genetic vulnerability. Then other than that, neurotransmitters like dopamine or norepinephrine that can be involved in the alcoholism and other substance dependence. Okay. Behavioral theories, the patient takes alcohol as a reward. If you take some alcohol, you get if the patient is having some anxiety, some palpitations, and the patient is very nervous, and the patient takes alcohol, the anxiety, palpitation, nervousness, and the irritability will be reduced by taking the alcohol. So if he takes alcohol, all these symptoms will be reduced. The patient will get a reward effect. That reward will be the stimulus for the next intake. So that is the behavioral theory. That is called conditioning. Conditioning is the drug abuse is the result of conditioning. So if we get the reward from the euphoric, if the patient gets unpleasant effect from the first alcohol dose, if the first takes alcohol and he gets unpleasant effects like vomiting or nausea and abdominal pain, then he won't take alcohol at time. So the reward is main reason for taking repeated intake of alcohol. Psychogenic factors, the patient may take because of very low self-esteem. The patient is having depression. The patient is living alone, and the patient is very lonely. And the patient is having some psychiatric disorders. The patient is going to take some pleasure seeking. Then normally we can see the daily wages. Coolie workers daily takes alcohol, around 180 ml of alcohol, to reduce their body pain and pleasure seeking. So that is one of the psychological factors. Social factors is peer pressure. Almost 80% of the substance use disorders starts at the age of 15 years. That is around 10th standard or 11th standard. At the time they will start. Main culprit for starting this substance is the peer pressure. Your student or neighbor colleague will be a culprit for starting your substance disorder. So peer pressure, just take it. So peer pressure is the main reason for alcohol, any substance intake. Unemployment, poor social support, and effect of television, TV. If the some actor or actress taking smoking or alcohol, then the child will experience that, experiment that. In the around 15 years of age, that actor Vijay or Ajit is taking alcohol and smoking. Why can't I? So I will also take alcohol. So that is the effect of television and other mass media. So that is also important risk factor for all taking alcohol or substance. And occupation, as I told earlier, coolies, daily wage workers, they can use alcohol daily. So, and another more thing, easy availability of drugs. Nowadays, there is Tasmark in every street. Tasmark, and we can get cigarettes easily in any shop in Tamil Nadu as well as in India. So Tasmarks are seen in almost 2 to 3 Tasmarks in a single street nowadays. So it's the easy availability of drugs. Second most things, doctor itself, some doctors other than psychiatrists, they prescribe some sleeping pills for temporary sleeping, but the patient misuse that for long period of time. So other than that, other risk factors is the patient is having psychiatric disorders like depression, anxiety, or schizophrenia, bipolar, the patient can take alcohol. Because to satisfy their effect and due to the illness also they take alcohol. Alcohol or any substances. So what are the consequences of substance abuse? We know many, almost all substances will produce some ill effects. So it will produce to physical dependence and psychological dependence. So what will happen is chronic substance abuse will cause us social and occupational functioning, create personal problems in the family, financial problems. We can go to debt, legal problems. If we go and hit a car, or if we go create a road traffic accident, then will lead to court case. So that the legal problems will be happen. And in pregnant women, if the patient takes alcohol, the pregnant woman takes alcohol, it leads to fetal loss. The baby will die. And so in long chronic alcohol use or any substance use, that will lead to psychiatric disorders, induced psychotic disorders. So IV drug users will be used for many life-threatening complications, including HIV. Mainly IV drug abuse will be IV drug abuse will produces HIV and other sexually transmitted diseases. Right. So as far as our de-addiction, my de-addiction center is concerned, we harbors more than, almost if your census is around 30, almost 25% of the patients will be, almost 90% will be alcohol patients. So the most commonly easily available pleasure and ease of cost. Ease of cost is very important because cannabis will be or a small package will be around 500 to 1000 rupees. But alcohol will be very cheap. That will be around 100 rupees to 200 rupees. They can easily buy at any shops, any Tasmark shops. So there is no police restrictions. So they can easily get this out. So most of the substance will be the alcohol dependence syndrome. So alcohol, it's the Arabic word. Alcohol is derived from Arabic word known as essence, means essence. So they use initially for some leisure activities, recreational activities. They used. We call it a somabanam at the early stage. So and then it becomes a daily habit for on the late the early 90s, early 1900s. The British used to take as a daily habit. Then it comes to India. So alcoholism refers to chronic use of alcoholic beverages, and chronic dependence will produce us. As I told earlier, it will lead to social, occupational, and economic dysfunction. So properties of alcohol is a clear liquid. It is rapidly absorbed from the blood, gut, and it's more stays in the bloodstream for more than 14 days. And absorption of alcohol is slower when food is in the stomach, and small amount of alcohol is excreted through urine, and small amount is exhaled through breath. So this is the general concentration of to this we can identify in what level of blood alcohol concentration the patient is there. So if there is 0.0 to 0.05, the patient is having mild impairment. If you see an alcohol intoxicated patient, then the patient is having mild speech or memory inattention and just balance impairment. He cannot stand steadily. So as he takes more amount of alcohol, his blood alcohol concentration will increases. If it goes up to 0.31 to 0.45, that will lead to life-threatening complications like death, coma and death. So this is the process of alcoholism. Whoever the patient is, alcoholism, the patient takes experimentally. First use, they use it for experiment. As I told you earlier, just take it. First use is experimental stage. Then is recreational stage. They can use for recreation purposes, social drinking, misuse of the drugs. And the third one is relaxation. So daily they use alcohol for relaxation, and finally they go for compulsion, otherwise called dependence. So this is a spectrum of psychoactive substance use. First, they're using beneficial use. This is a beneficial use. Beneficial uses that can use for medical pharmaceuticals. Cannabis can be used as a medicine also for some joint disorders. So it can be used as a beneficial use. Then it comes at the non-problematic or casual use. That is called social drinking. They can go for a party, social gathering. They can drink. That's called a casual or non-problematic use. And come to the problematic use. Problematic uses, they can drink to the task and come to home and create nuisance in the home as well as in the neighborhood. And third, last one is chronic dependence. That is, without alcohol, the patient cannot live. That is the chronic dependence phase. So how alcohol attacks brain? 3 stages it can attack the brain. One is in the forebrain. If it attacks the forebrain, it will cause motor incoordination and decision making. The patient cannot stand still. And second, it attacks the midbrain. There will be loss of emotions and increased chance of blackout. And finally, alcohol affects brainstem. Brainstem, if it is affected, then we need to affect the heart rate and respiration. That is the last stage. If the patient goes for coma and death. So ICD-10 criteria is a strong desire for taking the substance, that is alcohol, difficulty in controlling substance taking behavior, and the physiological withdrawal state of the removal of the drug, and the progressive neglect of alternative pleasure. That is, I cannot go to cinema. If the cinema is a previously pleasurable activity, now I want to go to cinema. I want only alcohol. That is the progressive neglect of other substances, and the persisting with the substance use disorder in spite clear evidence of harmful consequences. Even if he knows that his liver is going to get damaged, he will take alcohol. So psychiatric disorders due to alcohol dependence, we can see this is under 4 headings: acute intoxication, withdrawals, alcohol-induced amnestic disorder, and alcohol-induced psychiatric disorders. Why it is important for you? We are going to see nursing responsibility in this all courses psychiatric disorders. Why is the patient is the addiction admitted in the case of acute withdrawal syndrome in de-addiction center. Mostly most patients will get resolved in de-addiction center withdrawal symptoms within 5 days. Therefore, only we are sending the patient to de-addiction center after 5 days. But there is a term called delayed withdrawal. The patient will have withdrawal symptoms for more than 15 days. At that time, you have to manage the patient. Nursing staffs will have to manage the patient in de-addiction center. So manage the withdrawal in the de-addiction center. So we have to see the nursing responsibility, how nurses can see the withdrawal symptoms, treat the withdrawal symptoms, even if there is no doctor available in the de-addiction center. So acute intoxication, we all know, we can see intoxicated patients in the roads. So it is characterized by mood lability, slurred speech will be slurred, unsteady gait, nystagmus, finally resulting in stupor or coma if it is blood alcohol concentration is high. So this is alcohol withdrawal symptoms. So it's called simple withdrawal. What is called simple withdrawal? The patient is taking 180 ml of alcohol daily, and the patient removes the alcohol on the last day before admission. He will experience mild tremors or nausea or vomiting, some sort of anger outburst, and sleep disturbance, mainly sleep disturbance, insomnia, anxiety. So this is a simple withdrawal. So simple withdrawal will take around 24 hours. Within 24 hours, it can happen. If the simple withdrawal resolves within 24 hours, then there is no chance of getting another withdrawal symptoms or another over the next few days. If the simple withdrawal is very severe, then it goes for withdrawal seizures. It can go for withdrawal seizures. Withdrawal seizures, you can expect in 48 hours. The patient will have a gentle tonic-clonic fit attacks, and we can experience delirium tremors. That is called a confusion. The patient is going for confusion. That is can last up to 7 days, from 2nd to 7 days. If you go for confusion, the patient will be very, very difficult to manage in the de-addiction center, because the patient will be having hallucinations and delusions, and the patient will be very restless and trying to attack every inmate. So this is delirium tremens. This is used within 2 to 4 hours of complete abstinence of heavy drinking. So the course is very short. Okay. So if the patient is already, as I told, the patient is having disorientation. The patient will not know where he is. Whom the neighbor is standing behind the patient, and the patient is having vivid hallucinations and delusions, and the patient is having strong fear that somebody is trying to attack him. The patient will see snakes in his bed. The patient will see insects in his bed. The patient will have raised blood pressure and temperature. The patient will have elevated blood test results. So this is the time you have to be very conscious. So how to treat the withdrawal symptoms? We have to adequately treat the patient with benzodiazepine. Make the patient sleep. So if the patient if you make the patient sleep, the patient will be devoid of withdrawal symptom for the next 4 to 5 days. So other than that, the normal benzodiazepine we are giving is diazepam or nitrazepam in divided doses, almost 40 to 80 milligram per day doses. So prevent the withdrawal. And other drugs are used are thiamine, mainly vitamin B, thiamine supplementation, because vitamin supplementation is very necessary for the acute withdrawal period, because there will be depletion of the nutrients in the acute withdrawal period. And anticonvulsants for if the patient that goes for withdrawal seizures, and maintaining the fluid and electrolyte balance. So close observation is essential. So induced amnestic disorder, it can happen very late. So it is after over 1 month or 2 months after the patient stops alcohol, the patient will having amnestic disorder, that is memory loss. So the patient will be having Wernicke syndrome or Korsakoff syndrome. You might have studied in your book what is Wernicke syndrome. Wernicke syndrome is nothing but some ataxia, some neuropathy, peripheral neuropathy, and mental confusion. Korsakoff syndrome is made of disorientation, mainly confabulation. The patient will show approximate answers to your questions, and the patient will have poor digit span, attention span, and memory disturbances. So alcohol-induced psychiatric disorders, we can see anything. Alcohol-induced dementia, it can go for lifelong. Alcohol-induced mood disorders, anxiety, depression, alcohol-induced anxiety disorders, alcohol-induced seizures, alcohol-induced schizophrenia, alcohol-induced mood disorders. Anything can happen. So this is very important. After a course of stay in de-addiction center, after 30 days, we are going to assess the motivation, whether this patient will drink or not by this relapsing only. We have 5 stages: pre-contemplation, contemplation, preparation, action, maintenance. So what does pre-contemplation means? I am doing alcohol for my sake. I am good at alcohol. Why I have to stop? That is called pre-contemplation. There is no denial. I can't stop the alcohol. That is pre-contemplation. The contemplation is maybe that is the problem. Alcohol is the problem. I have to stop the alcohol. So kindly help me out. Help me out. That is called as contemplation phase. And the preparation is I am ready. I am ready to stop the alcohol or any substance. That is called as preparation phase. Action is I am already stopping the alcohol. This phase lasts for 3 to 6 months after the stoppage of alcohol. And finally is maintenance. Maintenance is over 6 months. So that is patient is living it. And relapse. Relapse is after the patient goes for maintenance. Then it after maintenance, after 1 to 2 years of maintenance, the patient gets relapse. Then it is called as relapse or recycle. So how can you identify relapse? This is called poor prognosis. How can we identify this patient will go for relapse in future, even after he is admitted in de-addiction center and rehabilitation center? We can identify what is the prognosis of this patient in the future. If you see the prognosis of what are the poor prognostic factors? If it is a forced admission, 4 to 5 members of family pick up the patient and put it in the de-addiction center, then it is called forced admission. Forced admission is one of the poor prognosis. The patient is not having any motivation to stop the alcohol, and the patient is having poor social support. The patient is divorced, and the patient is unmarried or single and living alone. Then the patient will go for relapse, quick relapse easily. And the patient is having jobless. The patient is jobless. Then he go for substance use, alcohol very easily, and the patient is having easy peer influence. Many friends who are taking alcohol, and frequent fights with family, and patient is having many psychiatric disorders like mania, schizophrenia. The patient will go for psychiatric disorder, substance alcohol use disorders. So what are the complications of alcohol abuse? We can know. So alcohol will damage almost every part of the body. So gastrointestinal, we can see diarrhea, esophageal cancers or gastritis, esophagitis, and neurological complications, as I told earlier, dementia, Korsakoff syndrome, peripheral neuropathy, alcohol neuropathy, seizures, fit attacks, Wernicke encephalopathies. So everything can happen. Cardiopulmonary, the patient will go for heart attacks, chronic obstructive pulmonary disease, COPD, increased risk of TB and HIV. Psychiatric complications, the patient will go for depression, anxiety, suicide, completed suicide or attempted suicide. That is the most important risk factor of alcohol. The patient he cannot know what he's doing under. He can under intoxication. The patient can take sleeping pills or multiple tablets under intoxication. Mainly, the attempted suicide patients, they take alcohol to clear the disinhibition about the suicide. So if he takes alcohol, they will be very much confident under to take the to attempt the suicide, and they will take the poison. So hepatic complications, the patient will go for liver cirrhosis, liver alcoholic liver cirrhosis and fatty liver. Other complications, that is mainly due to vitamin deficiencies, that is fetal alcohol syndrome, low sugars, diabetes. So this is the complications. So alcohol deterrent therapy, this is very, very important in case of nursing. So because the doctor will start on alcohol deterrent therapy, that is called disulfiram tablet, as I told earlier. So deterrent agent, or mainly the deterrent agents means, generally it means they will produce the unpleasant effect that I told earlier. The reward pressure effect will not be there when the tablets is mixed with alcohol. So when you mix the disulfiram with the alcohol, the patient will experience unpleasant effects. Mainly, the patient will have fatigue, dermatitis, vomiting, unpleasant. The patient will have unpleasant effect due to the alcohol. The patient will get the, as I told earlier, the alcohol is a result of conditioning. That conditioning will last, so that the patient will stop alcohol. If you get alcohol again, he will be in fear that he will get that again unpleasant symptoms again, so that he will stop taking alcohol. That is the alcohol deterrent therapy. What we use is disulfiram tablet. This tablet is around 500 milligram initial dose, 250 milligram, 500 milligram initial for first 2 weeks. Then we can give for 250 milligram per day. And main contraindication is if the patient is having any heart diseases or pulmonary diseases and kidney diseases, we cannot use this tablet. And if the patient, it can be used if the patient is willing to take this tablet. That is very, very important, because what happens is if the patient takes alcohol, the patient takes alcohol with this tablet, the patient can go for respiratory collapse, myocardial infarction, that is heart attack and death. So the patient is willing to take this tablet. Okay, sir, I'm ready to take this tablet. Even I will take this tablet and I will not drink alcohol. If the patient shows motivation after 30 days, then only we will put this tablet. So we will put this tablet on the 21st day after first CE. I will tell CE what it is. So your responsibility, nursing responsibility in deterrent therapy is you have to take a consent before starting the disulfiram tablet. You should ensure 12 hours before taking, that is, the patient should take the alcohol 12 hours before taking this tablet. Because if he takes tablet within 12 hours, the patient will develop alcohol disulfiram reactions. The patient should be warned against the ingestion of any alcohol content, mainly cough syrup. The patient cannot take cough syrup also, because there will be mild amount of alcohol in cough syrup, some sauces, ketchups, and aftershave lotions. Aftershave lotions begins the patient will have the aftershave lotions contains high amount of alcohol. So patient, you have to advise the patient you should carry a card, disulfiram card in your pocket that indicate that shows that if the patient is unconscious and lying on the road, the patient might have taken alcohol, and you have to take him immediately to the hospital. It is useful for general public. If the patient is lying on the road, the general public will take that card and will take to the hospital. So instruct the patient to avoid driving or other activities requiring alcohol. Patients cannot drive after taking. He cannot drive in the night. Mainly drive in the night after taking disulfiram. So he should be warned about the disulfiram alcohol reaction before 2 weeks after starting the dose, and you should carry the identification cards. So listing the name and the phone number of the physician to be called upon. In case we gave our number, alcohol Athma hotline number, if the patient is lying on the road. So if the patient lying on the road after taking alcohol and disulfiram, they will call up. So we have to emphasize the importance of follow-up visit if the patient is on disulfiram. This is your responsibility. All these are your responsibility. Doctor will just write the disulfiram and will tell the ill effects, but it's your responsibility to keep on telling the patients and come for follow-up visits. So psychological therapies, these are we at Athma De-Addiction Center, we using medications, and the medications is 50% useful if the patient is having mild motivation. If the patient is showing good motivation, the drugs will help for the most content, that is around 100%. But if the patient is having mild motivation, you have to improve the motivation. Then it is then the psychological therapy will help. Psychological therapies we are doing is what I have mentioned is we are doing here: motivational interviewing, group therapy, aversive conditioning, cognitive therapy, relapse prevention technique, cue exposure technique, assertive training, behavior counseling, supportive therapy, and individual therapy, and even family therapy also. So if the patient goes into the de-addiction center, he will be there in 25 days without seeing his family, and we will be with his inmates. So the patient will start, we will start our activities for patients from morning 9 a.m. So it will be there till 6 p.m. in the evening. The patient will be fully engaged. He cannot sleep in the day. He will be fully engaged in the daytime. He has a lot of activities. I will show the photographs of taken in the de-addiction center. De-addiction center in the about the activities and the psychological therapies what we are doing. So this is the group activity we are doing in the Athma de-addiction center. The patient will be divided into the groups. Mainly this group activity to increase their attention span, their decision making, they improve their cohort support, and other to improve their self-confidence. We are doing this group activity. So we asked to do some craft works and other some general knowledge questions, quiz items we can do. This group activities. The patient is doing some activities with the help of threats, and this is games. The patient will be given gaming for 1 to 2 hours. So gaming is not like just cards or just that gambling games. We are giving games to improve his consciousness, to improve his physical well-being, and we are giving games and at that instance, and the counselor will instruct the patient to do this, to how to tell the rules of the game, and you have to nursing staff. We have to monitor the patient whether the patient is doing with the correct way. And this is group therapy. Actually, this is the patient. Actually, the patient sitting the bench is already the patient who has been de-addicted in the de-addiction center, and he's been on maintenance. He will talk about the ill effects of alcohol and the aftermath after admitted in the de-addiction center. Obviously, his life. He will talk about that. So this is the motivational interviewing. We have 4 counselors, and they will do motivational interviewing daily. Almost daily, the patients will be seen by the counselor as well as by the doctor. Doctor in the case of physical aspects, and psychological aspects by the counselors. This is yoga therapy. We have one yoga therapist, and he will be given yoga therapy and meditation for 1 to 2 hours. And this is exercises. The patient will be given exercises and yoga for in the afternoon after the lunch periods. The patient will be asked to express the talents in the recreational time. Around 1 hour will be allotted for that. The patient they have some inherent talents. Somebody is good at speaking, somebody good at singing, somebody good at drawing. So they can express the talent in that 1 hour. So this is the group interview, motivational counseling regarding the ill effects of alcohol. And this is called CET. You can see the counselor sitting on the opposite side, and he is having a 180 ml of water bottle on his side, and the patient is being connected to a blood pressure apparatus, BP apparatus. So what we do is, we cannot rightly send the patient after 30 days, after the de-addiction center. What we do is, we can put the alcohol bottle in front of the patient, and we have to know whether some patients will say, yes, I will not drink alcohol, I will go out and remain abstinent. But we cannot rely on that. We rely only on records. So this is the record maintenance. So what we record is, we do a Q exposure therapy. Q means we keep this alcohol bottle in front of the patient for 30 minutes. We record the blood pressure and pulse rate and temperature of the patient every 5 minutes for 30 minutes. So we do almost 6 interval sessions we do. So at that time, we see that if there is any increase in BP or heart rate, then we can identify the patient is still having craving for alcohol, even because alcohol is placed in front of him. So he will be fully seen that alcohol only. If a doctor, motivational counselor will ask about various questions about alcohol, but he will be seeing that alcohol only. But with the blood pressure monitor and the temperature and the pulse rate, we can identify whether the patient will go for craving relapse after the discharge from the de-addiction center. We do see 2 CETs with a gap of 5 days. So there is 2 CETs is negative. There is positive. There is a failed test. Then we can go for another 1 more month in de-addiction center. Even after failed treatment in 2 months of de-addiction center, we transfer to rehabilitation center. So Alcohol Anonymous, this is what I told. This is aftermath of the de-addiction center. That is after discharge from the de-addiction center, the patients will meet up in every fourth Sunday in our hospital. So this is the Pudiyur group, Alcohol Anonymous. There is a NGO. They develop, they conduct this Alcohol Anonymous meeting. So this is Alcohol Anonymous meeting. The patients with the family members will come. So they will tell how is the life. So there will be three sort of patients. The patients they are de-addicted recently, moderate, de-addicted in the recent past, and de-addicted in the very remote past. So that is so the de-addicted patients in the remote past will tell about the how he is being living after the abstinence de-addiction from alcohol. So they will tell about the pleasant effects and ill effects of alcohol. So this is the Alcohol Anonymous meeting being held at every fourth Sunday in our hospital. This is the token of appreciation we give to the de-addicted patients who will be de-addicted for more than is being remain abstinent for more than 3 years. So there is a token of appreciation we give to them. So this is all about substance use disorder, alcohol. So other substance use disorder, we see all sorts of substances: cannabis, heroin, cocaine, LSD, even inhalants, tablets, benzodiazepine tablets, and we see many sorts of substances, almost all sorts of substances, even gaming addiction, everything we see. So we will see just light what are the intoxication and withdrawal symptoms of other substances. So cannabis, we know there are 4 forms of cannabis. Local term is ganja. So ganja, it can be either in smoked form or liquid form. Liquid form is bang. So there are 3 types of cannabis, 3 types of cannabinoids. One is endocannabinoids, that is prepared inside, that is derived inside our brain. That is more important for our alertness. Second one is phytocannabinoids, that is plant derived. That is what called ganja. That is very harmful. Then third one is synthetically cannabinoids, that is being prepared in the laboratory for many medical disorders. So all these are helpful in pain relieving, increasing the pleasure sensation and attention span. So acute intoxication, it will produce some euphoria-like effects, tachycardia, dry mouth and lacrimations, and increased appetite. Mainly increased appetite. The patient will eat like anything. The patient is taking cannabis. Normally, we cannot, if you are in a casualty and you see a patient eating very vigorously and you cannot identify what is the substance, you can rightly say that it's cannabis, because after alcohol, easily now available is cannabis. So severe intoxication will lead to depersonalization, derealization, and illusions and hallucinations. So withdrawal symptoms will produce hyperthirst, hyperthermia. That is, temperature will be above 100 degree and 104 degree Fahrenheit. There will be increased salivation, decreased appetite, and loss of weight. Complications: long-term ingestion of cannabis will lead to memory impairment. It can go to psychiatric disorders, mainly schizophrenia. Schizophrenia and cannabis are very well linked, and we can treat the patient with supportive and symptomatic management, because there is no specific deterrent medications for cannabis. We have a disulfiram for alcohol, but there is no deterrent medication for cannabis. So nicotine, easily available. You can get in any shop. You can get in any petty clinic. So nicotine abuse disorders, tobacco is the second most common abused substances after caffeine. All over the world. I'm telling all over the world. In India, it's first. So nicotine works through 4 areas. It enters the brain through bloodstream, and it activates the ventral tegmental area, nucleus accumbens, and the prefrontal cortex. Ventral tegmental area, it's helpful in release of dopamine. Nucleus accumbens is for reward. When you inhale, when you pick up a cigarette, you will get that relaxed sensation. That is called reward. Reward in the tobacco smoking. That reward is registered in this nucleus accumbens, and that reward will be memorized in the prefrontal cortex. This is for almost all substance use disorder. This is not only for nicotine, almost for all the substance. These 3 areas are very important: ventral tegmental area, nucleus accumbens, and prefrontal cortex. This prefrontal cortex in Tamil is called as Aramarivu. So risk from smoking, we know chronic disease will stroke, MI, pneumonia, head and neck cancers, almost all cancers. All cancers will have the risk factor of smoking, tobacco smoking. So nicotine dependence will produce if the patient is having dependent and you stop the smoking abruptly, then it produces decreased tensions, depressive feeling. The patient urge to take the smoke, impaired attention, the patient will be very much lethargic, and the skeletal muscles will be relaxed, and the patient will be very fatigued. Nicotine toxicity, as we have seen, nicotine toxicity is very, very rare. But for your completion sake, you just know about nicotine toxicity. Nicotine toxicity will lead to confusion and sensory disturbances. That's all. That is not a big issue. So, what is the treatment for nicotine therapy? We have first initially treat with nicotine gums, nicotine chewing gums, Nicotex. You can see in many medical shops, Nicotex gums and Nicotex lozenges and Nicotex patches. Patches is like a strip. We can place it here in the neck. A nicotine nasal spray, a nicotine inhalers. These are nicotine replacement therapies must be used. If we not get satisfied results in nicotine replacement therapy, then we can go for non-nicotine medications. We have two medications. One is bupropion tablet and the varenicline tablet. Two tablets we are having. Varenicline is a little expensive, but very helpful in smoking cessations. So this is the psychological therapy, behavioral therapy, aversion therapy, and hypnosis. So opioid use disorders is not much common in Tamil Nadu as far as concerned because it's morphine and heroin. But opioid is otherwise very useful in case of not, because we cannot get morphine and heroin as easily, but we can get some medical professionals use Fortrin and Phenergan. We use it in operational theaters. Operational theaters post-operational, we can give on the first day to relieve the pain of the operation. So we can Fortrin and Phenergan that Fortrin contains opioid, and also cough syrup. Cough syrup, if you get the Benadryl cough syrup contains opioid. So patient takes almost 6 bottles of Benadryl in a single day to get the pleasure effects of opioid. So morphine and heroin are a little bit less available in the market. So acute intoxication will produce pinpoint pupils, mainly pinpoint pupils, hypotension and bradycardia, delayed reflexes, thready pulse, and coma. Withdrawal symptoms, mainly running watery eyes, lacrimations from all the parts of the body. Increased secretions, mainly hypersalivation, hyper watery eyes, yawning, loss of appetite. These are the common symptoms. Cramps, diarrhea, increased urinations, increased body temperature. That will also be produced. That can be produced within 12 hours of the last dose if it takes opioid withdrawal. So overdose, we can treat with naloxone, naltrexone. 2 tablets are there. We can treat with the narcotic antagonist. Detoxification with clonidine, methadones, these type of tablets, and maintenance therapy with methadone and naltrexone. Behavior therapy is almost same for alcohol therapy, what I told earlier. So cocaine is also very much rare as far as Tamil Nadu is concerned, but we go for Bangalore and other states like major metropolitan cities like Mumbai and Delhi. It is easily been not we are getting our cocaine from Colombia, from almost South America. We are getting our cocaine, and it's been easily spotted. You can see a white powder snotting. It's called cocaine. So acute intoxication will produce same as the opioids, and patient will have pupillary dilatation. There will be pinpoint pupil in opioids, and there will be dilatation in cocaine, and there will be hypertension. The patient will be very restless if he gets intoxication, acutely intoxicated with cocaine. And withdrawal symptoms, we can see the agitation and depression. So management of intoxication of cocaine, we have amyl nitrate as a antidote. Other treatment will supportive management depending upon the symptoms. So LSD, you can see a very light strip. See, you can see the strip here. It's like a stamp. Local name is stamp. It's called stamp. It's freely available. It's very much available in Bangalore. So it is an LSD hallucinogen. Hallucinogen means what is which a substance which produces hallucinations. That is called as hallucinations. We know hallucinations. Hallucinations means காதுல குரல் கேட்பது, கண்ணில் உருவம் தெரிவது. So இது பேரு hallucinations. So the hallucinogen is a substance that produces hallucinations synthetically. That is called as hallucinogen. This is the one of hallucinogen. LSD that is easily available. Intoxication will produce hallucinations, illusions, depersonalization, derealizations, market judgment, and impairment. Withdrawal produce. So this is how we get. You see this picture. When you take the LSD stamp, if you take that LSD stamp in your tongue, it will get act within 1 to 2 minutes, and you will get a picture like this. This is the illusion. This is the illusion you will see. So this first picture is the illusion. You can see this is the visual you can see in your eyes. For this pleasant effect only, they are taking this repeated amount of LS. So as far as nursing interventions are concerned, in acute intoxication, what you do is care for a substance use patient, start with an assessment. Whatever doctor do, you do what substance he is abusing. Ask from the relatives, assess the signs and symptoms, how the patient is now, whether he is in acute intoxication or withdrawal, assess the symptoms, and how, because some some symptoms depends upon the dose. Symptoms of the intoxication get mark. So care for the assessment signs and symptoms upon depending upon the substance and dose. And during the acute phase of drug intoxication, maintain the patient's vital function. Check the maintain vital function, BP, pulse, temperature, saturations, and ensure his safety and easing discomfort. Because he has to be in a wide room, he should not be in a closed room. It should not be dark. The patient should be seeing. The patient's room should have a calendar. Patient should know about what is the date today, what is the year he is running. So everything he should know. During rehabilitation stage, you have to caregiver. Actually, you are a caregiver in the rehabilitation center. So caregiver help the patient to acknowledge his substance use problem. You have to tell about the substance use problem. That's why you are here, and you have to find the alternate ways to cope up with this stress and help the patient to achieve the recovery and state. Actually, that is the acute nursing intervention. So in acute episodes, continually monitor the patient's vitals, signs, and urine output, which for acute complications of overdose and withdrawal. The patient may have gone for overdose, then it is medical emergency. Then the patient has to be shifted to ICU. So withdrawal symptoms, the patient should be maintained in a safe and quiet environment. You have to take adequate measures to prevent the suicide attempts and assaults, and remove the harmful objects in the room, because the patient in confusion, the patient in acute confusion or acute withdrawal may try to attempt suicide in the way of escaping from the hospital. So you have to prevent that. So approach the patient in the non-threatening way. Limited sustained eye contact, which we have to see the patient by eye contact, and we have to take. We have to approach the patient. We cannot just like that say just be calm. So we have to see the eyes of the patient, and we have to respect the patient. Then only we will understand that some care is being given to him. So institute seizure precautions, administer adequate IV fluids, and give medications as ordered by the doctors. So in withdrawal state, maintain the same monitors and record the effectiveness of the withdrawal symptoms, maintain the quiet and safe environment, especially excessive noise may agitate the patient. The patient should be in a calm room, adequately ventilated room, and the patient adequately ventilated room and adequately lighted room. So when the acute episode has resolved, the patient is being now being normal. So then you carefully monitor and promote adequate nutrition, because the patient being getting out from the withdrawal stage, there will be a lot of depletion of nutrition. So you have to adequate nutrition, administer the drug carefully. You have to give drugs at the time. If you give drug for a breakfast, but that is for the morning dose, you have to give just before breakfast. You cannot give the afternoon dose and the night dose at the earliest, because the patient will keep the tablets, and he will keep the tablet, and he will hold the tablet, and he will take this, and he will attempt to the suicide with those tablets. So check the patient mouth to ensure he has swallowed the medication. That is very, very important. The patient will keep the tablet under his tongue. After you go out of the room, he will spit the tablet. So check the patient mouth that he is ensured he has swallowed the tablet. So closely monitor the visitor's movements. So you have to be, if the visitor is coming to see the patient, then you have to closely monitor, and you have to check the baggages of the visitors, that they are supplying any drugs from outside. So refer the patient for rehabilitation as appropriate. That is already told. There is more motivation after 2 months, and encourage the family members to seek help regardless of whether the abuser seeks it, and suggest private therapy or community health clinics. So prevention, there are 3 types of prevention. What we are doing in de-addiction center is tertiary prevention. So primary prevention is we have to reduce the sleeping pill doses. As we psychiatrists, we judiciously use benzodiazepines, but many physicians, many doctors use, they use sleeping pills to temporarily sleep the patient. If the patient complains of sleeping during the regular visit, they write alprazolam tablet. Alprazolam tablet is more dependent, more potential for get to dependent. So they write the alprazolam dependent. So that reduction of prescription will be, doctors should be encouraged. So if the patient, if you in your home or in your neighborhood, if the patient is taking too much amount of benzodiazepines, even after the doctor asks to stop it, then you have to be very cautious in primary preventing substance. So identification and treatment of family members who are contributing to drug abuse. The patient is taking one glass of alcohol, then it is also comes in a disorder. That itself you can take it to a doctor, because Sirutuli Peruvellam. So if the patient is taking his alcohol at the low amount, at the time it's very easy to prevent. So at the time you can go take to the hospital. So putting up other governmental measures to prevent the substances, putting up of the alcohol and other beverages substances to the high level. If the cannabis is used very low because its cost is very high, it's around 500 rupees to 1000 rupees. If they place the alcohol rate at the same level, 500 to 600, then it's not easily possible to daily wages to get the alcohol as easily from the Tasmak shop. So putting up the prices of alcohol will be a very good idea. Then controlling and abolishing the advertising of alcoholic drinks. The actors and the cricket players should not promote the alcohol at any instance. And the control of sales it should be limited for 2 hours only, for 3 hours only in the Tasmak shop. The control of sales will be a good idea, and the restricting the availability of the substance will be a good idea. So strengthen the individual's personal and social skills to increase the self-esteem. So if the patient, even after your friend is telling, just take it, is for fun only, just take it. You should not take the alcohol. That is the resistance to peer pressure that you have to encourage. That can be given by health education. So the health education to the college students and youth, you have to be tell, you have to treat. This is all the primary preventions. Secondary prevention is early detection and counseling. If the patient is taking alcohol or other substances once or twice in a week, then you take your doctor and secondly prevent it. We can, at that time, we can prevent by motivational interviewing and counseling itself. So at that time, we can mildly prescribe some sleeping pills and we can prevent it. So at that time, it's called secondary prevention. Tertiary prevention is what we are doing in the de-addiction center. Alcohol deterrent therapy, psychological therapies, alcohol anonymous meetings, motivation enhancing meetings, so assertive trainings. These are the tertiary preventions. So finally, rehabilitation. It's the last thing. After the patient is not showing any improvement, the patient is gone for any psychiatric disorders, or substance-induced psychiatric disorders, and it's very unlikely to manageable in home. Then we shift to the rehabilitation center. Rehabilitation center, we have a sheltered surroundings. We have around 120 inmates, and around 120 inmates, more than 40 inmates is being affected by substance use disorders, in substance use psychiatric disorders. So this is the rehabilitation. So that's all about our de-addiction center. Now I'll see about what are the de-addiction center doing at the community level. So we have a regular visits by nursing students in and around Trichy. So they come and stay in our de-addiction center for 15 days. We have a adequate hostel facility for them. They come and stay in there for 15 days, and they will observe each and every things going in the de-addiction center. So they will create a rally regarding the ill effects of de-addiction, alcohol addiction and de-addiction to the general public. So this is the de-addiction center at the community level. They go for rally. So this is our counselor doing motivational counseling, motivational talk regarding the reduction of substances in general public. And this is a camp we do every month to pick up the patients. Mainly I already told we have outreach to pick up the patients in all over Tamil Nadu. Wherever Tamil Nadu, we pick up the patients and we bring it to the de-addiction center. So this is the camp we do. So even if after the camp, the some patients refuse to come to de-addiction center. At the time, if the parents come and ask for help, we are ready to help the patients by sending our team, Athma de-addiction team, to the respective houses, that is respective town, and we pick up the patient from the houses. So we celebrate World De-Addiction Day on June 26th of every year. So every year we conduct some sort of programs, either in the form of rally or psychiatric quiz competitions, psychiatry conferences for nursing students. So this is a psychiatric quiz competition 2016. That's been happening every year with the trophy, overall trophy. This is around a 1 year, 1 day full program. There are a lot of programs will be there related to psychiatry only, not recreation, not related to psychiatry. Psychiatric quiz competition will be there. That's all. Almost have covered almost everything. So after the COVID, you come and visit our de-addiction center. If you get a chance, you come and visit the de-addiction center. It will be very useful. And as far as de-addiction center is concerned, you nurses are backbones. Even after psychiatrists visit once in a month, but you are the backbone in the de-addiction center. As far as concerned, hospital, psychiatric hospital is easy. Doctors will be available, consultants will be available. That is easy. But Athma de-addiction, that is de-addiction center. Athma, not only Athma, de-addiction center. Regarding de-addiction center, you are the backbone regarding management of patients in the de-addiction center. Outside Tamil Nadu, all over India, in Punjab, they are giving high salaries for de-addiction. That is a psychiatric nurse. That is nursing, BSc nursing or MSc nursing, trained in psychiatry. Yeah. They are given salary up to 1 lakh. That is the initial payment in Punjab, in other states in Tamil Nadu. So depending upon that, work is also there, because you have to run the de-addiction center. So that is what we are doing. So just if you know about addiction, de-addiction, dependence, what are the acute intoxication symptoms, addiction, de-addiction and dependence, and other what are the issues you have to manage, issues you are managing, you have to manage in the de-addiction center. If you know that, it's very easy to manage in the de-addiction center. So with this, I conclude my talk. If you have any questions, you can ask regarding de-addiction and addiction and any sort of thing. You can ask. Thank you.
Thanks, sir. Apart from the virtual visit in Athma hospitals, you have taken the de-addiction in detail for the students, especially in cure treatment for alcoholisms and nursing interventions about the de-addiction of substance abuses. Sir.
Any questions?
They didn't ask anything. I deemed it a great honor and privilege to propose the vote of thanks in this day. First and foremost, I thank our guest speaker, Dr. Ajay Muthukumar, Athma Hospital, Trichy, who despite his busy schedule, has found time to discuss the de-addiction session in detail with us. I want to thank Dr. Jayasudha, who is really a guiding and constant motivating force behind our endeavor. And I also express my heartfelt thanks to Professor Meera Saravanan, HOD of Mental Health Nursing, for her valuable contributions. I sincerely thanks to Mrs. Muthulakshmi, Assistant Professor, has arranged virtual visit in successful. And I thank our students for your cooperation in making visit in successful. You can anytime see this video in YouTube also. Thank you all.
Thank you.
Thanks, sir.